If your doctor just told you your blood pressure is finally perfect 120/80 and you are over 75 years old, you need to hear what I'm about to say because that ideal number could be killing you. Not high blood pressure, low blood pressure. A study published in JAMA Internal Medicine, one of the most respected medical journals in the world, tracked 1,542 adults over the age of 75 for 5 years. People with diabetes, people who had already strokes, people with heart failure, real patients, not cherry-picked textbook cases. And here is what they found. The elderly patients with so-called perfect blood pressure below 120 had 28% more serious falls requiring hospitalization and 14% higher overall mortality compared to patients whose pressure ran between 130 and 140. Read that again. The healthiest blood pressure, the one your doctor is chasing, was associated with more death. That is not a typo. That is the reality no one is telling you in the exam room. They are not going to bring this up at your next appointment. The system profits when you keep coming back, not when you walk out healthy. Subscribe to Dr. Waterling and hit like right now. Help this channel reach 100,000 subscribers. That is how we get this information to the people who need it most. I'm Sam Waterling, and I have spent 15 years watching this exact scenario play out in real patients. The overly medicated 78-year-old who falls in the middle of the night, the 82-year-old whose kidneys start failing, the patient who is told she is doing great while she grabs the wall every time she stands up. Today I'm going to explain why the standard blood pressure guidelines after age 75 are not just outdated, they are dangerous. I am going to tell you what blood pressure range is actually associated with the longest survival in older adults. And I am going to walk you through one simple 3-minute test you can do at home tonight with a device you can buy for about $30 at any pharmacy that can prevent a catastrophic fall before it ever happens. Let's start with what happens every single day in thousands of doctors' offices across this country. A patient walks in, 78 years old. Blood pressure reads 145/86. The doctor glances at the screen, sees the target below 130, and reaches for the prescription pad. One medication, then a second. 6 months later, blood pressure is 124/78. The doctor is pleased. The patient gets a gold star. Everyone assumes it worked. But here is what actually happens next. That same patient gets up at dash in the morning to use the bathroom. In a matter of seconds, blood pressure drops from 124 down to 88/56. The brain stops receiving enough blood. The room spins. A hand reaches for the wall and misses. Now, we are not talking about blood pressure numbers anymore. We are talking about a hip fracture, emergency surgery, 3 weeks of rehabilitation, and a cascade of complications that too often ends in permanent loss of independence or worse. This scenario plays out thousands of times a day in the United States, and it is preventable if you understand that the rules for a 50-year-old do not apply to an 80-year-old. Let me explain exactly why. For decades, medicine operated on one core principle: lower blood pressure is always better. And for people in their 40s and 50s, that is genuinely true. Reducing blood pressure in midlife really does protect against heart attack, stroke, and kidney disease. The evidence for that is rock solid. But after age 75, something fundamentally changes in the body. The same numbers mean something completely different. There are 3 key biological shifts that happen with aging, and together they explain why older adults need higher blood pressure targets, not lower ones. The first is arterial stiffness. Your arteries are supposed to be flexible. They expand when blood rushes in and spring back to maintain steady flow. With age, arterial walls stiffen and harden. This process is called arteriosclerosis. Think of it as the walls of your blood vessels losing their elasticity, like an old garden hose that is dried and cracked in the sun. When the heart pushes blood into rigid arteries, Those vessels cannot absorb and buffer the pressure the way young elastic ones do. To get adequate blood flow all the way to the brain and kidneys, especially when you are standing upright and blood has to travel against gravity, your body needs a higher baseline pressure just to do the same job. The second shift is declining baroreceptor sensitivity. Baroreceptors are tiny pressure sensors embedded in the walls of your blood vessels. Their job is to detect sudden changes in blood pressure and instantly signal the brain to compensate. In a young person who stands up from a chair, baroreceptors fire within milliseconds. The heart speeds up, blood vessels tighten, pressure stabilizes. With age, these sensors slow down. The compensatory response becomes sluggish and delayed. If baseline blood pressure is already being pushed low by medication, any sudden positional change can trigger a dangerous pressure crash. This is called orthostatic hypotension, a sudden drop in blood pressure when you change position from lying or sitting to standing. It causes dizziness and falls, and it is far more common than most patients or doctors recognize. The third shift is changes in drug metabolism. Your kidneys and liver at age 75 do not process medications the same way they did at 45. They clear drugs from the body more slowly. The same dose perfectly in a middle-aged patient lingers longer in an older body, acts more powerfully than intended, and can drive blood pressure dangerously low, even if the number on the cuff still looks fine when you are sitting still. Now, back to that study. 1,542 people over age 75, a real-world population with all the messiness that comes with aging. Researchers divided them into groups based on systolic blood pressure. That is the top number, the first figure you see when you take a reading. The groups were below 120, 120 to 130, 130 to 140, 140 to 150, and above 150. The results were striking. The lowest mortality was found in the group with blood pressure between 130 and 140, not the textbook perfect group below 120. Patients who maintained pressure below 120 had 28% more serious falls requiring hospitalization. They had higher rates of acute kidney injury. That means the kidneys suddenly and sharply stopped doing their job of filtering waste from the blood, and their overall mortality was 14% higher than patients in the 130 to 140 range. The group above 150 did have more strokes and cardiovascular events, so very high pressure is still a problem. But here is the uncomfortable truth. Being too low was just as dangerous as being too high. The optimal zone sits higher than current standard guidelines recommend. Let me make this concrete with a real clinical scenario. You are 76 years old. You come in for a routine checkup. Blood pressure is 142/84. Your doctor prescribes one medication, then adds a second 4 months later. At your next visit, blood pressure is 122/76. Your doctor says, excellent. But you start noticing something. When you stand up to answer the phone, there is a moment where your vision dims. When you push back from the dinner table, the room tilts slightly. You mention it to your doctor. The response? That's normal with age. Just get up more slowly. But what is actually happening is this. Your blood pressure, which looks beautiful on a sitting measurement, drops from 122 down to 95 the moment you stand. Your brain is being starved of blood repeatedly every time you change position. You are in a high-risk category for a life-altering fall, and nobody is checking for it because the sitting number looks like it came out of a textbook. Here is how you catch this problem yourself. Tonight, before you go to bed, the test is called orthostatic blood pressure measurement. Most doctors do not do it routinely, but you can do it at home with a standard blood pressure cuff, the kind available at any pharmacy for around $30. The protocol is simple. Lie down on your bed or couch and rest quietly for 5 full minutes. While still lying flat, take your blood pressure and write down both numbers. Then stand up immediately. Do not wait. and take a second reading right away while standing. Write those down too. Now, compare. If the top number, the systolic, drops by more than 20 points, or the bottom number, the diastolic, drops by more than 10 points, that is orthostatic hypotension. That is a red flag. It means your medications may be too strong or your blood pressure target is set too low for your individual physiology. Here's a concrete example of what a dangerous result looks like. Lying down, 125/78, looks completely normal. Standing, 98/64. That is a 27-point drop in systolic pressure. That is dangerous. Your brain is receiving insufficient blood flow for the entire duration that you are on your feet, which is most of your waking hours. If you are over 70 and taking blood pressure medication, this test belongs in every doctor's visit. If your doctor is not doing it, do it yourself and bring the written results to your next appointment. Now, let's talk about the actual numbers. What blood pressure is genuinely optimal at different ages based on current evidence? For adults between 65 and 74 who are reasonably healthy and physically active, the optimal systolic target is 130 to 140. This provides cardiovascular protection without creating a risk of hypoperfusion, meaning the organs do not get enough blood flow. For adults between 75 and 84 who are in relatively good health, the optimal range shifts upward to 135 to 145, higher than the younger group. This accounts for increased arterial stiffness and the slower baroreceptor response I described earlier for adults over 85 and for anyone who is physically frail. Regardless of age, a systolic blood pressure of 140 to 150 may be the most appropriate target. At this stage of life, preventing falls and preserving quality of life frequently matters more than driving numbers down aggressively. As for diastolic pressure, the bottom number. In older adults, it should not fall below 65. The optimal range is 70 to 85. Very low diastolic pressure reduces blood flow to the heart muscle itself during the relaxation phase, the moment when the heart refills its own blood supply. If your diastolic is consistently sitting below 65, bring that up with your doctor, even if the top number looks fine. Let me show you why this requires individualized thinking, not a one-size-fits-all number. Take two patients, both 81 years old, both walking in with a reading of 158/88, identical numbers. But the first patient has mild heart failure, stage 3 chronic kidney disease, and osteoarthritis. The second patient is healthy, active, golfs twice a week, and has no major medical conditions. Same age, same blood pressure, completely different clinical picture. For the first patient, aggressive multi-drug therapy is a serious risk. The pressure may crash upon standing, the medications may accelerate kidney damage. Dizziness with osteoarthritis is a recipe for a catastrophic fall. The right approach here is lifestyle changes first, and if medication is truly needed, the lowest possible dose of a single agent with careful monitoring, targeting 140 to 145, not 120. For the second healthy 81-year-old, 158 may warrant some attention, but even here, lifestyle modification alone might bring him to 145, which is a perfectly acceptable outcome without a single pill. This is what it means to treat the person, not the number. So, why are doctors still following outdated guidelines? Because medicine moves slowly. The large landmark trials that established the 120/80 target enrolled predominantly middle-aged patients. When those results came out, the recommendations were applied universally to everyone, regardless of age. The assumption was that what works for a 50-year-old must work for an 80-year-old. Over the past decade, researchers began studying specifically older patient populations, and what they found is that one size absolutely does not fit all. But new evidence takes years to reach clinical guidelines, and from guideline publication to actual change in day-to-day practice takes years more. many physicians today are still operating from protocols that are 5 to 10 years old. Add 15-minute appointment slots that leave no room for individualized nuance, and you have a system that treats numbers, not human beings. There is also a powerful psychological factor at work. Generations of medical training hammered one message into doctors: lower blood pressure saves lives. That reflex runs deep. Shifting from lower is always better to moderately elevated pressure can be appropriate, even protective. In certain older patients, requires critical thinking about each individual case. In today's medical system, that kind of individualized thinking is extraordinarily hard to apply consistently. Here is a clinical fact worth sitting with. After age 75, the risk of orthostatic hypotension and its associated falls rises sharply, precisely because all three mechanisms I described compound each other simultaneously: stiffened arteries, sluggish baroreceptors, and slowed drug clearance. After 75, a single fall can change everything: your mobility, your independence, your entire trajectory. This is the age where blood pressure management stops being an abstract number game and becomes a direct quality of life issue. People over 75 respond to blood pressure medications very differently than younger adults, and the risk-benefit calculation shifts in ways that most standard checklists do not capture. How old are you? Write your age in the comments below. I want to see the age distribution of this audience because the risk factors, the target ranges, and the practical advice I give you depend heavily on where you actually are in that picture. Here is exactly what you should do after watching this. Step 1. If you are over 70 and taking blood pressure medication, get a home blood pressure monitor if you do not already have one. Measure your pressure every morning and every evening at the same time each day for 2 weeks straight. Keep a written log. This gives you an accurate picture of your true average blood pressure, not one random clinic reading. Step 2. Do the orthostatic test I described. Lie flat for 5 minutes, measure, stand up, measure immediately again. If systolic drops more than 20 points or diastolic drops more than 10, write it down and bring it to your doctor. Step 3. Honestly evaluate your symptoms. Do you feel dizzy or lightheaded when you stand, unexplained fatigue, brain fog, or difficulty concentrating? These can all be signs that your blood pressure is running too low, even when the cuff reading looks normal. Step 4. Make a specific appointment to discuss your blood pressure targets, not just your readings. Do not automatically accept the formula of 120/80 as your goal. Ask your doctor directly, given my age, my specific health conditions, and my physical status, what is the right target range for me as an individual? Bring your 2-week log. Bring your orthostatic test results.
Show up as an informed participant in your own care, not a passive recipient of a prescription. Step 5. If you are experiencing side effects from blood pressure medications, dizziness, weakness, mental fog, say so explicitly. Do not dismiss these as just getting old. Dosages can be adjusted, medications can be changed, and treatment targets can be revised in a way that still protects your heart and vessels, but eliminates the dangerous side effects. You do not have to choose between your blood pressure numbers and your ability to stand up safely. The evidence is clear and the data is real. Standard blood pressure targets of 120/80 are not appropriate for adults over 75. A large, rigorous study involving 15,242 real-world patients demonstrates that pressure below 120 in this age group increases the risk of serious falls, acute kidney injury, orthostatic hypotension, and death. The optimal systolic range for most people over 75 is 130 to 145.
The older and more physically vulnerable the patient, the higher the acceptable upper boundary. Diastolic pressure should not fall below 65. Do the orthostatic test tonight. Start your measurement log. Have a direct, specific conversation with your doctor about your individual target, not a population average. Your blood pressure, your age, and your medical history are yours. They require a response tailored to you. Nobody in a white coat at a clinic appointment is going to walk you through what you just learned. There is no billing code for spending 20 minutes explaining individualized blood pressure targets to an elderly patient. The system is not built to keep you informed, it is built to keep you returning. Subscribe to Dr. Watling and leave a like. We are building something different here, one honest conversation at a time. Help this channel reach is how this information reaches the people who need it.